Thank you very much. First and foremost, I want to say I'm very happy to be speaking at the program of the network. The network is doing great work, and I must say that for me, it's claiming April 7 as a day to fight for against commercialization and marketization is very important for the kind of counter-hegemonic practice and narrative that we need to win this odious battle. So without much ado, I would go to the presentation now. Uh, okay, all right. I would use some slides just to, okay. All right, so we'll look at the drivers, mechanisms, and impacts of the commercialization of health on the global south. Uh, well, so I think it's important to stress a few things, even in moving forward. One of which is, I mean, the understanding the way and manner of the commercialization of health in the global south, as well as in the world generally. It flows from seeing how the world itself has changed in the period after World War II until the Alma Ata conference of 1978. There was, I mean, great steps, bounds were made in Africa, for example. Even if it wasn't much, the number of doctors per populate by without 10,000, it doubled, and you had governments putting in money into public health. But by the late 70s, early 80s, this changed as the neoliberal paradigm of development, or I would say mal-development, became the global order. And the global south was badly hit with the structural adjustment programs and the impact of this on health care. And as we'll look further on, things moved from bad to terrible when we got even into the 21st century. And that's why, even though the 80s and to some extent 90s are considered lost decades in Latin America, in Africa, things have actually gone from bad to worse, from bad to actually terrible in the 21st century. Now, I group the drivers and the mechanisms they use. They are intertwined, of course, into three. The international financial institutions play an overarching role in setting the context of commercialization of health, and it started as part of the structural adjustment programs of the 80s. One of the first form of attacks against the efforts to build to realize the right to health in the global south, despite challenges in the 60s, in the early 70s, came in 1981 with two reports, the Berg reports, that was focused on Africa, acceleration of development, quite ironic in Africa, but it was also applied across the global south. And then there was David De Ferranti's report, and these two pushed for the introduction of user fees by the late 90s into the early 2000s. After it was clear that SAP was a failure, but also because civil society organizations, trade unions, mobilized, and there was a pushback. So you had some changes. You had uh, talking of some basic health packages, talking of introduction of some form of universal health coverage gradually started becoming a thing, and we look at the issue of even universal health coverage, because universal health coverage, which has been touted even by World Bank, World Health Organization, is not necessarily the same thing as universal public health care. And that brings us to the issue of the second key drivers. I mean, you see, the universal health coverage, there's an ideological element to this within the broader context of commercialization of health. You see more of these being used to promote private health insurance and subsidizing private providers with public funds. I'll give an example with Kenya. In Kenya, between July 2018 and February 2019, 1,266 private providers, they accessed $20 million from the National Health Insurance Fund, while 5,751 public health facilities accessed just 7,000 from the same fund. Now, when you break it down, it gets even more ridiculous, in that you see that each public health institution got added together just 9% of what an average, what one private hospital got. But, and this is the funny thing, the public providers are larger. To put this in perspective, the National West Hospital, one of the leading private hospitals, but it's the 8th largest hospital in all. It had 1.4 million from that amount. But the 2 largest hospitals in the country, and which are tertiary health institutions, public hospitals, they added together, they got $1.5 million. So it's like subsidizing private providers. It is not as if it is about that. Then you see increasing vertical integration in the private provision, where a number of you now have consortiums. You even have efforts at they say there's what they call now about the business of health in Africa, and you see similar things in Latin America, and with this being linked with the private and not only with the insurance but corporations in general. And it's important to also stress the role of the philanthrocapitalist foundations and international development agencies. They have played key roles in making commercialization of health care seem natural. The philanthrocapitalist foundations, not only with the money they put in, but also with the kind of authority that they wield, including through the World Health Organization, including on governments in the global south, have been able to normalize the idea of privatization in different forms within healthcare delivery in the global south. And this, it's as I said, it started in the 80s, but has gotten worse now. When it started in the 80s, the 90s, you saw outright, then it was, now you have more of outright privatization in parts of Africa. But before then, like in India in the 90s, it started with even over 300 contracting outsourcing of diagnostics in hospitals. Then later it even moved to primary healthcare centers. The same thing you see in Ghana, in Nigeria. They started with contracting out of non-clinical services. But you now even have contracting out of labor, where instead of you have increasingly contract staff, even despite the fact that you have you have shortage of staff, but you also have so many people, inadequate really, nurses, health technicians, but who are looking for jobs and then get to work only on contract. And the public-private partnerships, international development agencies in particular, also are quite guilty of that. And a few years back, there was the European body of arbitrators pointed this out, that the public-private partnerships in healthcare it does not in any way aid the realization of the right to health. And a number of civil society organizations in Europe as well also pointed out the Eurodad, as well as the Jubilee campaign, even took on bodies like the DFID to ask that, well, whilst you are now standing against this in UK, for example, why is the DFID promoting continued public-private partnerships in the global south, despite the fact that this have not in any way helped to address the health crisis in this part of the world. Now, the impacts have been quite dear, despite the arguments of commercialization leading to efficiency and all that. 52% of people in Africa do not have access to the formal health system. But this is just a tip of the iceberg, because amongst even those that have access, you have what is effectively a two-tiered system. An example is with South Africa, where only recently they move into having the national health insurance, but you still have the medical aid schemes, and which is being subsidized with monies from the national health insurance, and which is something that it is the affluent that have access to this. And I give an example here when they talk about, with regards to poor service integration and service quality for the poor with Brazil. As you might know, the first case of COVID-19 in Brazil was of a rich woman who traveled on vacation and then returned. And but she didn't inform her maid and people working with her. But the long and short is that the maids became, that was in the Rio de Janeiro region in Brazil. The maid contracted the COVID from her and became the first person in Rio de Janeiro, the first fatality of COVID, and the fifth in Brazil as a whole. And for me, that is like a sharp reflection of different different service quality. Because when the maid got ill, and this is the interesting, she went home, went to a local clinic that she could, but she couldn't. She lost her life. So this is a metaphor of what you have with regards to the rich being able to access, in some cases, first world standard of healthcare, but the poor being unable to access this. And increasing commercialization has been used to justify, to reinforce governments not funding public health care adequately. In Nigeria, for example, over the years, up till as of last year, the out-of-pocket expenditure has been, it has fluctuated between 74 and 79% of expenditure on health. And what this means is that, this health inequity then reinforces social inequity. Also because of the poor funding of healthcare systems in Latin America, for example, despite the fact that you have witnessed improvements when you look at the old figures. For example, maternal and child mortality, has been improved by some 40%, but behind those figures, as a result of the commercialization of health, behind those figures, those that are poor, those that are indigenous people, uh, pregnancy is still a major, like according to the World Bank itself, it pointed out that it remains the number one killer of mothers and children. They are 3 to 4 times likely, a woman is 3 to 4 times likelier to die from pregnancy related conditions in Latin America if she's indigenous. So it reinforces a number of social class and race and ethnicity as a result of such situation. And you have a major shortage of health and care workers in these different countries. The WHO, the United Nations, actually the high level health, employment, and economic growth commission pointed out then, it's 6 years back, that by 2018 there will be a shortfall of some 18 million workers. 80% of that shortfall would be in the global south, particularly Africa and parts of Asia. But you have also then seen increased health worker migration because workers are underpaid. You had over 800 labor disputes in the health sector during the pandemic period, and a reasonable number of these, we're in the global south, and it's partly because they hardly get paid on them. So all these are further leading to the worsening of health inequities in the different parts of the global south. Now, I think the question is, what is to be done? How? What can we do? It's important to challenge these drivers of the commercialization of health and with evidence-based rebuttal of their ideological justification of the of the mechanisms. But it's not that the evidence has been there. This keep being raised, and we have to keep raising it. But the thing is, the most difficult person to wake up is not the person that is actually sleeping. It is the person that is pretending to sleep. And that is why I say it is ideological justifications. It is quite clear that commercialization of health, it is not only that it leads to further health inequities, it is also that it is in no way, it does not have the efficiency that it is claimed to have. So and this is part of why I said I was very happy with being with the network. It is important to put forward the evidence, but it is also important to mobilize, to fight, to change things. And that takes me to the lesson from from the Alma Ata Declaration. One of the things that is not often recalled when people speak of the Alma Ata Declaration right to health is that it was clearly stated there that to achieve the right to health for all by 2000, this was in 1978, there was the need, for a new international economic order. You will recall that this was a call of the global south in 1973. A lot has changed since then, but the simple fact is that, and most of it for the worse with the neoliberal counter-revolution, but without structural changing of the global order, with on the basis of an anti-neoliberal agenda, it will be impossible, or at least near impossible, to stop this continued commercialization of health. And to do this, we need to build solidarity within and across borders. That is one of the things that, PSI is doing, one of the things that the network is doing. Would also work with, even with some in the government, like when I spoke about Kenya now. One of the persons that our affiliates got across to push this through is a former general secretary of one of the affiliates of the PSI there, who now is a member of parliament there. We need to look for allies within, but as well beyond, the state, and we need to build power from below to challenge this and to stop this. I'm sorry to say this nonsense is actually it's a tragic nonsense. Thank you very much.